looking forward to the next speaker to enter the room. Oh, there he is. So Dr. Colin Barker is one of our key established interventional structural cardiologists, and I promised him he's welcome to our heart failure meeting. And the truth is we collaborated over the last several years. He's been a key member here. He completed his medical school training in Boston University, followed by residency and internship at Vanderbilt, fellowship at NYU, followed by a more advanced heart interventional fellowship at Scripps, and has been on staff here for several years. And he is going to give us an update on valve surgery for patients with heart failure, both surgery and percutaneous options. Colin, as always, thank you.
Thank you, John. Great, and thanks. It's always good to be a part of this conference. So I'm going to narrow this down to 3 lesions that we primarily end up tackling and addressing people with heart failure. The first is going to be aortic stenosis, and we'll focus a little bit on low flow, low gradient aortic stenosis, what that means, how we tease that out. Mitral regurgitation has become a more complex lesion that we treat, and primarily because all MR is not equal. We now dichotomize the disease into what's functional, i.e. related to a dilated annulus and heart failure, primarily, which because the medicines work so well, we're a little hesitant to treat those people surgically or percutaneously these days outside of a clinical trial, versus degenerative MR, and we'll go through a few cases. And finally, highlight the new kid on the block that we have some options for treating, and that's tricuspid regurgitation, primarily being treated percutaneous rather than surgically. So here's an 88-year-old gentleman that was actually referred to us from our heart failure colleagues who had coronary artery disease, bad lung disease, vascular disease, an ejection fraction of 20%, RV failure, thrombocytopenia, and had multiple recent admissions with decompensated heart failure. His echo from various hospitals and offices had very unclear how bad his aortic stenosis was. Because he'd had so many hospitalizations, he was actually getting planned for a CardioMEMS. So aside from being 88, he's very functional and independent, takes care of his wife, who's very sick, and he's able to really do just about everything. His STS risk for isolated aortic valve surgery is significantly higher than most people would take on these days. So here is his LV. You can see it's very weak and dilated. Here's his aortic valve. It appears not to be opening, and there's clearly some turbulence across it. This is looking, oops, let me go back one. This is looking down on the aortic valve, and this is how we primarily judge the significance of aortic stenosis. So this is a Doppler measurement across the aortic valve, and there are certain criteria that he would need to meet in order for us to deem it severe. And really, he doesn't deem that. And sometimes when we have confusion, we'll take people to the cath lab and invasively measure their hemodynamics. And his gradient was 14 millimeters of mercury. And generally, if someone has severe aortic stenosis, their mean gradient should be closer to 40 millimeters of mercury. So the overall picture here is a gentleman with a significantly reduced ejection fraction, biventricular failure, a mean gradient of only 15. So if we treat this with a surgical valve or a transcatheter valve, we'll probably get this down to somewhere between 7 and 10 millimeters, ideally. So the question is, how much are we actually going to improve this gentleman? He also has other valvular lesions. So one thing that we try to tease out when we get faced with cases like this, is it actually a valve lesion or is this a myocardial lesion? Is the muscle what's failing? And this is what we would call pseudo-severe aortic stenosis, or more commonly, is it both? And one way to tease the two out is doing a dobutamine stress test, sort of a modified dobutamine stress test in the echo lab. So here are 2 cases, both at baseline look the same. This is a cartoon of an aortic valve. And there's one that's classified as low flow, and then here's one we're going to end up classifying as pseudo. So what we see here is when the valve is in systole, it opens. And when you give dobutamine, it's still not fully opening, and the velocity, that Doppler we looked at across the aortic valve, actually increased. So this is true aortic stenosis. This is a fixed lesion. The valve is not opening. It's a mechanical problem. This is someone who would benefit from some sort of intervention on the aortic valve. As opposed to this case, where somebody has a valve that's not opening, but when you give them a drug to increase their contractility, subsequently the valve opens, and this would not be severe aortic stenosis. This would be someone who has pseudo-aortic valve stenosis and does not need or warrant or would benefit from any intervention on their aortic valve. So he had a dobutamine stress echo. We got him up to 30 mics, which is actually a little higher than usually. His stroke volume did not increase significantly. His valve area continued to be tight. And so the conclusion was, well, this is the unfortunate case of someone who does have both a valvular issue and a myocardial issue. So he has severe aortic stenosis with no flow reserve. So one thing we can use as a tiebreaker is measuring the amount of calcification on the aortic valve, and we use that on a CAT scan here. And so here, you're looking at two separate patients, and this white stuff, that's the calcium. And you can see in this patient, there's a significant degree of calcium, whereas on that patient, there's really minimal calcium. And so if we had faced with a patient like this, and we scanned them, and we see that degree of calcium, we'll be a little bit more confident that this is potentially someone who would benefit from a valvular intervention, which is what he got. So that's what sorry, I went through that a little quick, but this is what the TAVR looks like. It's sort of a metal cage with a prosthetic valve done percutaneously and transfemorally. And here was his post-intervention hemodynamics really showing no gradient across his aortic valve anymore. And here's his post-procedural transthoracic echo showing his ejection. His heart actually might look a little better, at least subjectively. Clearly, there's no more gradient across the aortic valve. Here is where the prosthesis is. So he had a very uneventful recovery, went home. At 30-day follow-up and 1-year follow-up is doing well. Unfortunately, his wife passed away, but he was able to get remarried. And this was now 3 years ago, and he continues to do very well. So, a tough case, but I think in this situation, we made the right call. For the mitral valve, we're a little bit limited as far as percutaneous actual prosthetic valve replacements. All of those various devices are still not approved in the United States and are still only being used in the context of a clinical trial. There's a lot of limitations for doing mitral valve replacements percutaneously, as well as surgically in very sick patients with heart failure. So the only device that we have and use routinely right now is something called a Mitral Clip, which I'll show you. And it has several advantages over some of the percutaneous valve replacement options. So this is what the catheter looks like. It's a little bigger than my pinky. It goes through the femoral vein in your groin up to the heart, where we do a transeptal puncture and then deliver this device, which is about the size of a dime. And we use it to grab onto the leaky parts of the mitral valve. In these cartoons, this is sort of looking en face at the mitral valve. And then we leave it in place as long as it's not causing too much obstruction or mitral stenosis. A and B, we've done something to improve the degree of mitral regurgitation, but also I think more importantly, we routinely measure hemodynamics during these procedures now. And we want to make sure we've had a significant improvement on left atrial pressure. This has now become widely used throughout the world, but one interesting thing is to look at how it's used around the world. So here's what I was talking about. This is all the cases that have been done in the world, and it breaks it down by the etiology of the mitral regurgitation that's been treated. And you can see an overwhelming majority are treated for functional mitral regurgitation, which is a normal valve. It's just sitting in an annulus that's enlarged, so the leaflets aren't coapting. The annulus is stretched out. So those are the patients with functional MR, as opposed to degenerative MR, which is when you have a flail leaflet or a prolapse leaflet. And in the United States, 90% of the patients being treated are treated for degenerative MR. Outside the United States, most people are treated for functional MR. And part of it is because we're doing trials looking at heart failure patients, and frankly, the medications have gotten so good. A lot of these patients we screen with significant functional mitral regurgitation get better, and they don't need or warrant any intervention. And we'll know a little bit more about that in September of this year when the Coapt trial data is presented, which compared patients with significant functional MR to some sort of intervention versus a medical therapy. And here's just a peek at the roll-in patients in the Coapt trial. And remember, these were patients who had been admitted at least once in the past 12 months for decompensated heart failure, were too high risk for surgery, and then were randomized to a mitral clip intervention versus a optimal medical therapy, heart failure medical therapy. And so the event rates were very low with this pretty sick population, 0% deaths at 30 days. Heart failure readmissions fairly low compared to a sort of standard pretty sick group like this. But probably most importantly, their quality of life improved significantly. These are KCQ-12 quality of life questionnaires, which are validated quality of life measurements. And generally, once you get a change in your score of 5 to 10 points, you've made a meaningful impact on that person's quality of life. So clearly, it may benefit some patients, but we really have to wait and see when we compare this in the randomized controlled trial. Here, this is all the data that looked at both surgical mitral repair and replacement versus mitral clip in the randomized controlled trials that had been done. And the top graph is looking at NYHA improvement, and the bottom here is the top is looking at mitral regurgitation improvement, and the bottom here is looking at NYHA improvement. And this is looking at not only 12 months, but now out to 5 years. And we have 5-year data now that shows people continue to feel good and have an improvement in their mitral regurgitation. It's important to realize it's not perfect. With a mitral clip procedure, people do leave the procedure with some residual mitral regurgitation, but based usually on our invasive hemodynamics, it's tolerable and an improvement from whatever their starting degree of MR was. And this is illustrated here. Again, this is a composite of all the patients that were treated in the early clinical trials, looking at their hemodynamic responses, both immediately during the procedure and then at 24 hours. And you see the cardiac output goes up significantly with the index, the LV end diastolic pressure comes down, forward stroke volumes go up significantly, and LV end diastolic volumes come down. So all sort of pointing in the right direction as far as hemodynamic responses. And it's also a device that can be used not only to treat standalone mitral regurgitation, but this was a patient who had severe MR. This is what the mitral clip looks like after it's implanted on an echocardiogram. But this was someone who had severe MR secondary to systolic anterior motion of the mitral valve and left ventricular outflow tract obstruction. And what you can see here is the pre-hemodynamics where this lady had a 100-millimeter gradient across her left ventricular outflow tract. And after treating both the mitral regurgitation and pulling the anterior leaflet back a little bit out of the LVOT, her mean gradient went down to 14, and then subsequently on beta blockers has come down to 0. And another sort of unique case here that we treated a few years ago was a guy who had bypass surgery about 6 months ago, but then it sort of suffered in an LTAC. His EF dropped. He was on chronic milrinone therapy. It had developed acute on chronic, but now renal failure, and was on dialysis, and really hadn't been out of bed in 6 months, and had a perforated leaflet in his posterior mitral valve, as well as some central mitral regurgitation. And here in this 3D view, you're looking down the barrel of the mitral valve. You can see this hole right here where the nice little arrow sign is, and also a lack of coaptation during systole. So you have two mechanisms for a leaky valve. And what we were able to do is actually treat both of those lesions with the first thing we put in was a little vascular plug that we used to close ASDs or other holes in the heart, and then a mitral clip, and essentially reduced his leak down to trace. And over the he was in the hospital for 2 or 3 more weeks, but came off the inotropes, was able to go transfer back to an LTAC and undergo more meaningful rehab. So the last lesion I'll touch on before wrapping up here is the tricuspid valve, which for us has become a new player just as devices and technology have evolved where we have more meaningful potential interventions. Obviously, we've been dealing with tricuspid regurgitation for a while, but it's had its challenges. One of the issues we have to be aware of when we're doing interventions on the tricuspid valve, and I'll show you a couple examples, is the other players in the neighborhood, specifically the right coronary artery running very adjacent to the annulus, which can be problematic. In general, the tricuspid valve and annulus is the largest of the four valves. It's 20% larger than the mitral valve. It's not planar. It has some three-dimensional configuration to it with some apically displaced segments both anteriorly and posteriorly. And what we deal with mostly, and you guys would see this more than we do, we all ultimately get these people sort of later in the game, but they're almost all exclusively what we would call functional tricuspid regurgitation, in that in this free aspect of the tricuspid annulus, it dilates out, therefore inhibiting the leaflets from being able to coapt during systole and causing a leaky valve. The etiologies of primary, which again are rare, but we don't infrequently see, primarily are from us, either defibrillators or pacemakers, recurrent biopsies, infections, or inflammatory issues. But by far what we see is what's this called secondary or functional tricuspid regurgitation, meaning it's a result of something else upstream, left-sided heart disease, valvular disease, lung disease, volume overload states, and other obstructive issues. But we know that people with isolated tricuspid regurgitation don't do well, and this is a large series of patients who had isolated tricuspid regurgitation and were stratified according to their effective regurgitant orifice. So this is survival out to 10 years. You can see patients with significant tricuspid regurgitation have poor survival compared to a similar population without tricuspid regurgitation. And as you would expect, their cardiac event rates are much higher, 30 to 60% over 5 to 10 years. And it's regardless of symptoms. When the patients are broken down into those who are asymptomatic versus those who are symptomatic from their tricuspid regurgitation, again, the green bars are showing those with EROAs greater than 40, which means they have severe tricuspid regurgitation, poor survival, more event rates compared to those without tricuspid regurgitation. When you go to the guidelines for what are the recommendations as far as intervening or doing any surgery on the tricuspid valve, these two green boxes are the only class 1 indications for doing tricuspid valve surgery. And if you go up, you see both of them are only in the setting of left-sided valve surgery. So there's no class 1 indication because it's a high-risk operation. The right ventricle is notoriously potentially weak and can't respond to an insult like surgery. So there's no class 1 indication for isolated tricuspid valve surgery. So there's an opportunity for transcatheter therapies, and something we've got more involved in over the past year. Presently, there's a spectrum of devices out there. Clearly, not all of them are going to be successful, and frankly, some of them have already sort of gone away. But there are a couple I'll highlight. One is something we've done here, and that's use the tricuspid clip, the mitral clip in the tricuspid position. And in order to prepare for our first case, we did a 3D printed model of our patient. So this was the actual patient we were going to treat. And in our flow lab, did some sampling and testing of which leaflets were going to be the most likely to be able to be grasped and the most successful in minimizing the tricuspid regurgitation. And as the name implies, there are 3 leaflets in the tricuspid valve, an anterior, posterior, and septal. And it turns out if we grasp the anterior septal commissure, that's where we get the most successful and meaningful result. And this was one of our first cases that our structural fellow wrote up and published in the European Heart Journal. But if you just look at the color Doppler, here's the tricuspid regurgitation pre and post. So probably about a 50 to 60% reduction with the mitral clip in the tricuspid position. But this guy had, he was cirrhotic, had ascites, was getting paracentesis every week. His legs were tree trunks. And in the first week after we did this procedure, he diuresed almost 22 liters without us having to do anything. He just suddenly had real forward flow going. And that was about a year and a half ago, and he continues to do well. This is a trial we've just recently started. This is a percutaneous, this is a transjugular percutaneous annuloplasty, basically, where we bicuspidize the tricuspid valve. So we implant these two sutures percutaneously and then pull them together to shrink up the orifice to basically, which is similar to a surgical operation that's done. And here's an example of a case. So this is in the cath lab. You're seeing fluoroscopy. One of the things to notice here, we have wires in the right coronary artery because that can get compromised. These little dots are those plegited sutures, and you can see the distance between them from there to there decreased. So that's pulling everything together. The right coronary is not compromised. And pre and post, here you see really no coaptation with wide open tricuspid regurgitation. And afterward, much better coaptation with minimal tricuspid regurgitation, and also significant hemodynamic improvements with right atrial pressure that went from 22 to 9, and left ventricular stroke volume that went from 42 cc's up to 72 cc's. And again, here's what the baseline echo looked like with this wide open TR and the follow-up. And one thing to note is we still have severe TR, but we've improved it significantly, over 50%, and it appears that that might be enough to improve these patients clinically. This is the initial data on that device that showed improvements in NYHA functional class, quality of life questionnaires, and other tests. There's been now a multi-center European study looking at all tricuspid interventions. And one of the struggles here is getting meaningful endpoints, but I'll just jump to the last slide here. One thing that we've seen is this significant change in doses of medications, in that at baseline, people are on very, very high doses of diuretics with tricuspid regurgitation, because that's really our only meaningful intervention. And you can see these doses from 150 milligrams of Lasix come down to more sort of normal 20 to 40 milligrams, similar to torsemide at 30 days. So probably potentially a meaningful result, but clearly indicative of a successful therapy. So with that, I'll thank you for your time.
Colin, thank you for that wonderful review. You're going away so quickly. We do have a few minutes for a question, maybe one question or two. But you know, we're going to break in a couple of minutes. But anybody have any questions related to this really evolving, exciting technology? And certainly, as heart failure specialists, there's a real potential need and use here. And one of our concerns is that benefit risk and distinguishing out advanced heart failure that may be too much for you guys. If you could just comment on when you feel that, you know, the patient's underlying profile is preclusive of, I mean, you've alluded to it in many ways, but preclusive of something to be done in the cath lab.
Really, Jerry, as you know, we do things here in such a multidisciplinary fashion. We rely on you guys. I firmly believe after our experience in Coapt and seeing a lot of these functional MR patients get better on really good aggressive heart failure therapy, you know, that's the front line, that's in their indicated frontline therapy. But then when people get to a point where their ejection fraction is less than 20%, that's the other spectrum where I don't think we're going to be able to help them very much. We could harm them. I mean, one of the things we see is, you know, when we fix these regurgitant lesions, particularly MRs, the EF actually gets worse when you take off that reverse flow pop-off valve, and some people can get very sick. So we're still teasing out, you know, the right person. For the right side, we're really trying to figure that out, because now all we're seeing is these real end-stage RV failure people who, you know, touching them with anything is very risky, but obviously having everyone involved, I think, helps.
Good morning, Dr. Barker. We were watching the video of how they put that on while you were speaking and putting it on. Do they have a high percentage of it, like the skill to put it on, a high percentage of it slipping off or ripping the leaflet valves? Because it looks like when you're watching it, the video, it looks like they're just dropping it in and putting it on, but then as it is palpating up and down, it looks like it would
Yep.
kind of ripped the leaflet valves more.
So there's a couple things we do. When we put it on, we go through a couple of test maneuvers to make sure we have enough tissue and it's not going to come off. But that being said, when you look at the TVT registry, there's a 1.3% what we call single leaflet detachment, which is where it does pull off. And so that's problematic. Obviously, usually they need to go for surgery or a redo intervention, but it's about 1.3%.
Colin, I think I'd like to point out that we appreciate all of the work that interventional guys do on our patients, and the heart failure is becoming more and more multidisciplinary in working together with you guys. And with that comment, my question is for the tricuspid valve, how does the presence of the ICD lead, which most of our patients have, play into all these new therapies?
So it's hard for, and that's, the other person on our team now is obviously one of the EP guys to come up with sometimes unique things to do with the different devices that can be in place. It's a contraindication for the Triline device I showed. We've done mitral clips in the tricuspid position on patients who have defibrillators. The challenge there is sometimes just the imaging artifacts and actually seeing where we are, because this is all echo-based guided with usually TEE or ICE. But we haven't had any problems, and based on our EP recommendations, we'll wait a minimum of 3 months after an implant before doing anything, so we don't cause anything to come loose.
Colin, real quick, I know you mentioned that choosing the right patient is a tough task, especially with these early interventions in the tricuspid valve. If you were to, just based on the limited experience, and I know we're just starting to do these valves, and from what you've seen, and what would you recommend to referring cardiologists in terms of which type of patient should be considered for tricuspid valve intervention?
I think anyone who has symptomatic moderate to severe TR who doesn't have some other reversible cause for it, untreated pulmonary hypertension, some obviously left-sided lesions, and doesn't have, some hugely dilated heart with biventricular failure. So that's the one end of the spectrum, but the other end of the spectrum where it's probably a little too late is, and the challenge is the cirrhotic patient getting these, we did that because that was sort of a almost palliative procedure, and we got permission to do that. But I think somewhere in between, when someone's starting to show some signs of right heart failure, they've been treated, there's no reversible cause, and this is an issue. It actually turns out it's right now, because we've screened over 120, 150 patients for this and narrowed it down to 4 or 5. So it's a rare bird that has truly isolated tricuspid regurgitation without something else going on. But it does exist, but I think down the road we can treat people who have more mixed disease.
How did y'all make the 3D model? What equipment did we have here to generate that so you could practice?
Oh, we have a flow lab that has access to a 3D printer. And it's part of a protocol we do. So we'll do 3D prints, and Dr. Lin does this too for the congenital cases. On anything that's going to be complex or a little unusual, we have access to 3D printers. And the issue, though, with there's various materials. You can make materials that are very similar to muscle, but it's the valve leaflets themselves are a little tricky to get material that's really sort of similar to what an actual heart valve is like. We've also, used some animal models as well.
So that's not off an MRI off that patient or anything like that. That's just
No, it is. Oh, it's off a CAT scan. Sorry.
a CAT scan. So
Yeah.
you guys could use the CAT scan.
So we use a CAT
print.
scan to print their heart.
Excellent.